Thank you very much for the invitation to address you today on the topic of does PCOS actually protect bone? Thank you very much for the organizing committee, and it's an honor to deliver this speech in India. I have no disclosures for this particular lecture. So let's first start off by one of the problems that we have in this discussion, and that what actually constitutes the syndrome of PCOS. And I reverted to the 2003 Rotterdam Consensus Workshop that concluded that PCOS is a syndrome characterized by ovarian dysfunction with cardinal features of hyperandrogenism, as well as the morphology of the ovaries showing a polycystic picture. But it should be understood that PCOS is a syndrome, and many clinical manifestations may include menstrual irregularities, signs of androgen excess, obesity, insulin resistance, elevated serum LH levels, as well as an increased risk of type 2 diabetes and cardiovascular diseases. So if we then want to see whether this syndrome has an effect on bone, we have to look at the definition of osteoporosis. So osteoporosis is defined as a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration, as you can see here, which leads to bone being weaker, in other words, enhanced bone fragility with a consequent increase in the risk of fracture. What is interesting then, if we have a look at these two conditions, we see that PCOS is a condition that mainly occurs in younger women. And if we have a look at what happens with bone, we see that in the same time where PCOS starts appearing in women is also the time where the peak bone mass is established. So a condition which affects young women may have an effect on the attainment of peak bone mass. So prior to 2014, there were several studies that suggested that PCOS actually offered a protective effect on bone mineral density. And at that stage, it was postulated to be an effect of the relative normal values of circulating E2. And we know that E2 is always good for bone. It inhibits in resorption of bone, and it stimulates the formation of new bone. And this is then also accompanied by increased androgen levels, which can be aromatized to 17-beta estradiol, especially in patients with obesity. And that there are also increased insulin levels, which they thought may be good for bone. So I've given you three examples here of the typical pre-2014 research done, which suggested then that PCOS does protect against bone. Since 2014, it was found that PCOS actually had a negative impact on bone mineral density. Women with PCOS had significantly lower bone mineral density at the lumbar spine compared to controls, especially in the normal weight group. It does seem that the deleterious effect of estrogen deficiency on bones in PCOS is not balanced by androgen overproduction and may also be linked to increased insulin production. And this was eventually in 2019 proven to be the more favorable effect of PCOS on bone. In other words, that it has a negative impact on bone by this systemic review and a meta-analysis of 80 high-quality studies done between 1919 and 2018. And in this meta-analysis, it was found that women with PCOS with BMI greater than or smaller than 27 kilograms per square meter had lower bone mineral density of the total femur and spine when compared with the control group, whereas women with a higher BMI, there was no difference. In other words, a negative effect on bone only in patients who were not overweight. They also had a look at osteocalcin, which is a marker of bone formation, and that was remarkably reduced in the women with the leaner body mass. They found that although the bone density was lower, they could not prove that the fracture rate actually increased between the PCOS patients and control. And they actually felt that this was a good scenario for further research to look at, and maybe to differentiate between patients in the earlier group nearer to attainment of peak bone mass versus older patients who had PCOS in earlier years. So we know from our definition of osteoporosis that lowered bone mass in itself is not necessarily a problem yet. The problem arises when that leads to fractures. So in this particular study, in 11,106 subjects aged 15 to 80 years with PCOS, and compared to respective age-matched controls without PCOS, and these patients all came from an insurance database, the following results were gained: that in comparison to controls, PCOS patients had an increased risk for any fracture, and with an adjusted hazard ratio of 1.23, statistical at the 95% confidence level. They had a higher incidence of osteoporotic fractures, and that's now any osteoporotic fracture, with adjusted hazard ratio of 1.33, again being significant, as well as an increase in spine fractures and forearm fractures. But at the hip, the femur, the humerus, the wrist, and other non-osteoporotic fractures, it was not increased. So in conclusion, this group then found that the PCOS group had a higher occurrence rate of fractures compared to non-PCOS patients. So how does this happen? What is the mechanism of action? Well, we actually don't quite know. There's been many factors that had been evaluated without getting to a definite answer. So this is open to further prospective research. But the most likely reason why PCOS is bad for bone is that the lower average estrogen levels compared to non-PCOS women, especially in the window period for attainment of peak bone mass, does not add up. Increased androgen levels generally do not compensate for the lower estrogen levels, except perhaps in overweight women. So we also just have to have a perspective if we talk about effect of bone and bone mineral density in PCOS, because this will mostly affect pre-menopausal women. So just remember that if you do a bone mineral density test on a premenopausal woman, you should use the Z score, or as the Americans say, the Z score, and not the T score. Now, whereas the T score will be lowered at a value of minus 1.5 or a value of minus 1, between 1 and minus 2.5, in the Z score, which is the age-adjusted score, it only is a problem if it drops below minus 2. So in premenopausal women, including then these PCOS patients, the term osteoporosis is only reserved for women with a low bone mineral density and fractures. And we should always remember with a premenopausal patient, if you do have low bone mineral density, that it is normally as a result of a secondary cause of low bone mineral density, and in this case being PCOS, and we would only use bone-specific medication such as a bisphosphonate in the immediate face of previous fractures or expected new fractures. So in PCOS patients, with the use of a combined oral contraceptive pill, that will most likely offer bone protection. Bone-specific medications such as the bisphosphonates will be the absolute exception and only in patients with fractures. We can, however, expect the fracture risk in PCOS patients who maybe only had it in the earlier phase of their life to have an expected or increased risk after menopause. So for that reason, it is important in all patients when they are diagnosed with PCOS to advise them on a bone-friendly lifestyle. So that would mean that their diet should be confirmed to the advised levels in your particular country for calcium and vitamin D. There should be sufficient protein in the diet. There should be an avoidance of bone toxic substances such as nicotine, that's smoking, and alcohol, as well as the chronic use of drugs such as glucocorticoids. The patient should also be advised on doing daily exercise. It should be weight-bearing exercise, and it should be at least 20 minutes for 5 days of the week. So in summary then, it can be stated with a high degree of confidence that PCOS does not offer bone protection. And this was the first question that was asked. It can be stated also with a high degree of confidence that PCOS is associated with lower levels of bone mineral density compared to controls, especially in lean women. It can also be stated that there's reasonable evidence to suspect that PCOS is associated with an increased fracture risk, and all PCOS patients should thus be advised on a bone-friendly lifestyle. Oral contraceptives most likely offers bone protection, and bone-specific drugs are rarely indicated in patients with PCOS without any fractures. But further research on the subject is certainly needed. I would advise, though, that all PCOS patients should have a DEXA exam at least at the start of menopause. At this stage, I'm hesitant to advise that all PCOS patients should have a DEXA exam. I think that you should, with all PCOS patients, only keep it in mind that it may be necessary to do that. I thank you very much for your attention.